Hi, my name is Jackie, and I am a nursing student at Aspen University. Today I'm going to be teaching you about asthma. Asthma is a chronic inflammation disorder that usually occurs when something that you breathe in irritates the bronchi and the bronchioles to become inflamed, and it starts an inflammation process that causes the bronchioles and the bronchi to become inflamed and create mucus. When this happens, the patient can have many different types of symptoms. And usually the best way to remember the symptoms is with the word asthma times 3. And that is, A is for accessory muscles use, S is for shortness of breath and dyspnea, T is for chest tightness, and also tachypnea, which is increased respiratory rates. H is for high-pitched wheezing. M is for minimal diminished breath sounds. And A is for absent breath sounds when it becomes really severe and the inflammation becomes too tight to where you can't get any oxygen in and out, which then can lead to acidosis, and it can also lead to air trapping. Usually what ends up happening when you typically breathe, I have a little model here for you, is that you have your trachea that comes straight down into your bronchi, into your bronchioles, that go all into your little alveoli down here. Alveoli down here, and then air ends up exchanging in between the alveoli, in between these capillary vessels that are down here, and air flows from high concentration to low concentration. So when you breathe in, the air gets pushed down into these things where air gas exchange can occur. And then when CO2 enters the lungs, it kind of exhales. So once you actually get going, the lungs themselves don't actually typically do any working besides gas exchange. What ends up making them inflate and deflate is actually your diaphragm. So I have a little model here with this bottle and balloons. And this balloon right here represents your diaphragm. So when your diaphragm actually comes down, your balloons inflate. That's what we call inhalation. So what happens in inhalation is that the diaphragm muscle actually contracts downward while your accessory muscles, your rib muscles, go upwards and kind of outward to expand, creating a larger increased cavity space here, decreasing the pressure that's inside of here, which then in turn makes the lungs expand. Now the same thing happens on the opposite side. When inhalation is where you can make the diaphragm contract, exhalation on the other hand is a passive motion, kind of happens on its own. There's no real extra force inside of that. We can force it, but it happens naturally on its own. And what ends up happening is that when the diaphragm relaxes, and everything kind of expands backwards, the cavity space kind of shrinks a little bit, the volume gets lower, and then the increased pressure kind of happens, and then the lungs deflate. So it's like that. So you got inhalation and exhalation, and then exhalation. So that's kind of cool just to kind of show you that way. What I ended up doing in making this, though, I did super glue everything, or not super glue, but hot glue gun on top of it. And the only reason why I did that was because I wanted to make sure that there wasn't any leaking, any airs inside of here. Because what happens when you have air leakage is that the lungs don't fully deflate like this. And then you have complications in that way. With asthma, though, what ends up happening is that these bronchioles, right here, I drew one for you. This is a typical normal bronchiole right here where it's pretty wide and you can get a lot of airflow kind of coming in. This one over here is really restricted. It's constricted. It's called the bronchial constriction. And it inflames up really big, just like the inflammation process. And then you have all this mucus secretion that kind of happens just like in the inflammation process. And makes it very difficult for air to kind of come in. Now, if it's swollen like this, air can possibly still kind of come in, but it's very difficult for them, really hard to breathe. Their gas exchange is going to be really kind of low. It can constrict all the way though, so remember that. So when it constricts all the way, that's when we really got to start worrying about the air trapping, because then air can't come in or out. The lungs build up with carbon dioxide, the body builds up with carbon dioxide, and then we end up with acidosis, and respiratory failure follows that. So that's a no-no. We don't want that. Things that we can kind of do to help our patients along the way in this is our biggest maintained thing is airway management. As a nurse, we want to make sure we have airway management with these patients, just so that we can have adequate oxygenation. And good ways that we can do that is we can teach them how to do the cough reflex, cough exercises, try to cough up some of this mucus down here that may be in the way and secreting if it's not completely closed. We have to listen to their lungs, because it will have a very loud, high-pitched wheezing noise, which almost sounds like you're whistling. But what we're really listening for also, not only just on top of the high-pitched wheezing, but if the wheezing stops, because that's not a good sign. We don't want the wheezing to just suddenly stop. That just means there is nothing happening, and we don't want to do that. So we really need to listen to their lung sounds, and then for diminished sounds as well. Continuously listening to them. We can teach them how to use the incentive spirometer to kind of see if we can expand the lungs a little bit. We can do an administrative humidified air, or even apply oxygen to these patients. Sit them inside of a position to where it really opens up the lung expansion so that they can hopefully try to get really deep breaths, which is another one. We want to teach them to take deep breaths. Slow, deep breaths as much as possible, because what ends up happening is that they'll end up slow exhaling, not slow inhaling, and we want them to inhale as much possible. And then we can also use medications. So down here, on this side, we have what's called the BAM and SLAM medications, which are typical for these patients. So your BAM medication is usually your number one, so that's your beta adrenergics, which is what typically is prescribed for these patients because it helps to open up the lungs. And then what we will do right afterwards is we'll also produce like a steroid inside of it to help reduce the inflammation that's inside the lungs. So we want to open the lungs and then reduce the inflammation that's going on. Hopefully, one, we want to get them air, and then two, we want to try to solve the problem. Your A's is going to be your anticholinergics. Your M is your methanoxidil. Sorry, I'm really bad with the words. Your L is your leukopenia inhalers, and then your M is your mast cell stabilizers. And what we really want to do in teaching these patients is that normally what happens if they have to take two medications is they take their beta adrenergics first. We really need to just open up those lungs. Once we get those lungs opened, they need to at least wait 5 minutes before they can move on and take the next medication, because you want to make sure the medication is working before you just pump this one in. If you pump this one in right afterwards, what ends up happening is that it all gets stuck right up in here and it does no good. The patient still can't breathe. Have to get the medication in, have to open up those lungs, at least wait for the medication to work to open up those lungs, and then we give them the steroid to at least try to reduce some of that inflammation that's going on. That is a good teaching point that nurses need to make for their patients. We have to teach them how to properly use their medication, or else they're going to end up with this stuck medication up here that does no good. Another thing that we should teach our patients is not only how to use the medication, but what to do after they use the medication. Sometimes inhalers can kind of cause thrush that builds up in the back of the throat. And the best thing for them to do is to brush their teeth after they actually take their medication. That prevents the actual thrush buildup. Another thing that we want to teach our patients is how to use a peak expiratory flow rate and monitor that, because that's going to help them understand if today's going to be a good day or not a good day. Another thing that we need to teach them, of course, how to take their medication, how to store their medication, and to know their triggers. Since this whole process usually occurs is because an allergen comes inside the system and touches these sensitive soft muscles enough to where they inflamed on their own, we want to make sure that they avoid their triggers as much as possible. So teaching them about their triggers is huge. We also want to teach our patients how to do pursed lip breathing to kind of help them. We want to teach them about using nebulizer treatments at home if they need to use those to help increase the oxygen flow or just the humidified air. We want to teach our patients to drink lots and lots of water. Not lots and lots of water, but lots of water, more than normal. Because increased water can help thin out this mucus secretion and it doesn't become so thick and trapped inside these lungs. We can actually get it out. Then that's coughing exercises. We teach them the coughing exercises. We can even get them to use the incentive-spirometer when they're inside the hospitals to try to see if we can open up their lung spans and try to get them to keep them open. And then on top of it, we want to teach them some relaxation techniques. Some triggers that mostly occur with patients, the most common triggers are smoking and pollen and cat dandruff and stress. Stress is a big one for our patients. That can cause a lot of problems for them. But cold air and perfume, strong odors, things like that, dust, strenuous exercise. So teaching our patients relaxation techniques, knowing their triggers, how to avoid this is going to best help them most of all. We also want to make sure that we teach them I ran out of my list. I guess teach them how to properly store their medication so that they know that they have a medication on them at all times if they actually do end up needing it versus leaving it at home. Because leaving your medication at home and you having an allergy attack at school doesn't really help you. So making sure that you actually have your inhaler with you at all times is a very important thing to teach patients. In the community, there are several places that patients can go to if they have asthma to help them, which one of them, a big one, is the CDC. They have a lot of information on there that help patients. You have the Arizona Asthma Coalition as well here in Arizona. The American Lung Association of Arizona. They even have camps for kids. It's kind of cool. They have camps called Not a Wheezy and Camp Soaring Eagles. They, if people have problems affording medications and things like that, the Arizona Department of Health Services have programs to where they can get them involved to kind of afford their medications or afford visits. Because one other thing that we need to teach them is to follow up with their physician. With their peak flow expiration rates, we want to make sure that if they're having a very bad day, like their blow rate is like say 280, what we want to do, even though it may be just for that time and they use their medication and their flow rate goes back up, have them follow up with their physician because chances are that means that they're going to need an additional medication. So always have them follow up with their physician. Even if they have just one bad reading, they still need to go see their physician and follow up with them. Sorry to jump subjects. So go back to the community sources. We have the American Lung Association, the American Asthma Association. Banner Health even has a really cool program too for kids especially. They have what's called the Peds Asthma, and they're a huge support group that kind of helps the kids kind of get out of their comfort zone, teaches them about the actual asthma, the pathophysiology of it, and they do activities with the kids to kind of get them out and about, to not really be afraid to be out. Because a lot of times they'll be so afraid of their triggers that they end up isolating themselves, and that's not what we want them to do. We want to teach them to know their triggers, to avoid them at certain times, have their medication on hand if they actually need it, but not to isolate themselves. This isn't something that isn't manageable. You can manage asthma, and that's the most important thing that we really need to teach our patients. Asthma attacks, they come and they go, but they are reversible. They're not going to stick around forever. And then another one that I actually thought was pretty cool was called the Breathmobile is what it was called. It's an actual mobile clinic that if you call them, they'll come to you, check you out, listen to your lung sounds, help you with medications if you need to, and things like that as well. I think I touched base on all of my subjects. Um, and thank you guys so much for watching. I hope you guys learned something.